Today we're going to look at the musculoskeletal system again and see how the muscles interrelate with the bones to produce both stability and movement in the body. And to do so, we're going to have to look at the physics of levers. The body has nearly 700 skeletal muscles, and these produce movement and stability by acting as levers in conjunction with the skeletal system and producing opposing forces and using what we call mechanical advantage in different ways, sometimes in very different ways. Long time ago, Archimedes said, "Give me a lever long enough and a place to stand, and I'll move the world." And this translates into what we do for the body as long as you understand the physics of simple levers. The most common lever that we see is the first-class lever, in which we have a fulcrum in the middle, and we have a weight at one end, and we apply our force to the other end. So I can move a weight here upward by applying a downward force. If my fulcrum is in the middle, I'll apply the same amount of force here as I'm having to move here, and I'll move this the same distance down as this moves up. That's a first-class lever. To make mechanical use of it, I can move my fulcrum here. If this distance is 10 times this distance, I could now move 10 pounds there with only 1 pound of force here. But I'm going to have to move it 10 times as far to get this to move 1 unit of distance. Now, very few of the levers in the body work this way. There's another kind of lever called a second-class lever. In this case, the fulcrum is at the end, the resistance is somewhere here in the middle, and my force is here. This is very much like a wheelbarrow. If I move my weight out here, I get very little mechanical advantage. What we do is we actually divide the distance between the fulcrum and my weight by the total distance. So if I move very, very close to the end of this fulcrum, I'll find this much easier to lift the weight. However, again, I'm going to have to move this a very long distance to move my weight very little. So I am gaining strength at the expense of distance and speed. The third kind of lever I have is if I have my fulcrum still here, I have my resistance here, or my weight, and I'm in the middle. Now, as I get farther out at this end, I'm getting closer to 1-to-1 ratios. But if I try to apply my force way here close, in order to lift this weight, I'm going to have to apply much more force. So a pound out here may take 10 pounds of force here, but look what I'm gaining. I only have to move a little bit to move this a great distance. All the muscles in the body use these principles to move bones around joints. The levers can increase either the strength of movement, or the speed of the movement, or the range of the movement, but they can't increase all three at once. You have to give up something when you're using a system of levers. We call this increased strength mechanical advantage, but then the range of motion is going to be diminished. And then if the range of motion is increased, the mechanical advantage is diminished. So let's talk a little bit about how the different levers in the body work by going to our first slide. If we look at one of the very few first-class levers we have in the body, it is the muscles in the back of the neck that keep our head up. We talked about this one. This is the voluntary muscle that makes your head fall when you fall asleep sitting up. Think about the different points. Here in this diagram and all our diagrams, F is the fulcrum, R is the resistance or the weight, and E is the effort that we're going to apply to move that weight. Here's the first-class fulcrum. In this case, the fulcrum is right in the middle. This effort is going to be the same as the resistance. Look what happens in the head. The head is balanced upon a bone up here called the atlas, the top vertebral bone, C1. And the weight of most of the head is in this portion. It tends to make the head drop down. So that's our resistance. Fulcrum is right here in the middle, and our effort is applied downward, pivoting on the fulcrum and lifting the head up. It's a first-class lever. We get very little mechanical advantage because of the way it's set up, but we don't need much of a range of motion either. So in this case, we're getting nearly 1-to-1, but it's a postural muscle. It's one that doesn't move very much. In the second class lever, the wheelbarrow example, we have here, and this is the calf muscle, which pulls on the bone at the back of our heel called the calcaneus and lifts us up onto our toes. This is a second class lever. The fulcrum is here, just as it is in the wheels of a wheelbarrow. The load or resistance is in the middle of our wheelbarrow, and we apply the effort to the end of the wheelbarrow. If the resistance is moved this way, we're going to get a lot of mechanical advantage, lift a much heavier weight with more ease, but we're going to have to lift farther to make the weight move. If we move the resistance out here, the opposite happens. We don't get the advantage, but we don't have to move it so far. The toe in this case, or the ball of the foot, is the fulcrum. The resistance is kind of far back, so we get very little mechanical advantage. This is the gastrocnemius muscle, which we'll see more of, the calf. It is attached up here at the knee and has its tendon down here and pulls upward. So when we lift up on our toe, we're getting a great deal of weight without much mechanical advantage, but we're able to lift it a pretty good distance, which is the benefit we're gaining in this case by using the extra effort. Finally, we have the third class lever, which is what most of the joints in our body use for a very special reason. The force here is located between the fulcrum and the weight. Again, just so you'll see this clearly, as we move the effort back to lift up, it becomes harder and harder to move this. So if we have our effort way back here on this slide, near the fulcrum, we're going to have to use a lot more force than the actual weight itself, but we'll get a lot of speed and range of motion. That's the biceps of the arm. That's the muscles of the legs. Here we have the biceps, which is attached to the shoulder, coming straight down very, very near the fulcrum, which is our elbow. This is showing its attachment to the bones of the arm. The force is exerted here. This is a great multiple of the distance out to the resistance, which is the weight. And what we're going to do here is have to exert a lot of force, but we're going to get this to move either a long distance or very fast, depending on which we want to have. So this range of motion and speed is gained at the expense of having to use a lot more weight. Flexion of the forearm on the upper arm when we're doing curls is the classic example of this one. Our thigh muscles do the same thing. They extend the lower leg on the knee when we contract our thighs in a kicking motion, but our attachment is very near the knee, just over the top of the knee and onto the top of our lower leg, and we gain a lot of speed for running or kicking at the expense of having to have very big, strong thigh muscles. Now, these are the physics of motion, and the next thing I need to do is tell you a little bit about the parts of the muscle and the skeletal system and how they attach, and then we need to talk a little bit about some of the terminology. Coming back to now another schematic of this bicep system, we've seen the lifting effort that the muscle requires. One of the other things we have to do is learn the common terminology. In general, anything that is near the top is proximal. Anything away from the top of whatever organ we're talking about or system is distal. And we have an origin to every muscle. Here's the biceps, and it originates right at the lip of our shoulder girdle and the clavicle, near the clavicle rather, as it attaches to our shoulder. It goes downward and it inserts on our forearm, right here. The origin is always defined, if we can define it, as the part of the muscle system that's not going to move much at all, if any. It's the stationary part, and then the insertion is always the part we're trying to move. You can figure this out for almost all of them. Those muscles in the back of our neck that inserted in our head, certainly the origin was down near our shoulder, and the insertion was up on our head because we moved our head that way. And we will always talk about the origin and the insertion. It's usually pretty clear, not too much to worry about there. We should also notice the difference between tendons and ligaments. I told you earlier that muscles are very weak in terms of tensile strength. You can tear them or rip them very easily, literally with your fingers. If you put a stitch through a muscle and tie it, it will cut through like ice. It won't hold the stitch very well. We have other structures that help in that regard. At the end of every muscle group is something called the tendon. And the tendon is a thickened, fibrous structure made of collagen, and it is what attaches the muscle to the bone that the muscle is going to move or from which it originates. So we have a tendon up here at the top of the biceps, and we have a tendon down here at the insertion. You'll often see on the bones a little raised area, sometimes called a tubercle, from just the reaction to being pulled on. The bone develops with a thickened area just under the tendon so that the insertion and origin are thickened to give better purchase on that bone. We'll see these a lot as we move through the skeleton. And then the middle portion of the muscle is called the belly of the muscle. See the same thing in the back. The origins of the triceps are up here near the shoulder, the insertion is on the elbow, and the belly is in the middle of the muscle. We also have ligaments, and these are often confused by some people as being the same as tendons, and they're not. Ligaments attach bone to bone. They don't have a muscular attachment. So it's the tendons that attach the muscle to the bone, ligaments attach bone to bone and provide stability for joints. Now, we name muscles by a great many different descriptions that go along with everything from size, shape, orientation, mechanical action, number of heads, and so on. And I need to go through this list once so then we can start talking about them. They make sense. Once you see them in the body, you'll then understand why we call them that. And when you correlate a name with a particular muscle, it'll make complete sense. So just follow this along without really trying to memorize this. First name we call several muscles is maximus or magnus. This means the largest of a group. In the buttock, we have the gluteus maximus, the largest muscle of that group. And to bring the leg on the thigh in to the other leg, we have the adductor magnus, one that pulls the leg in and is the largest of that group of muscles. We also conversely have minimus. Sitting underneath your gluteus maximus, which you're all sitting on now, is your gluteus minimus. It's just a smaller muscle. Several muscles are called longus because they are the longest of the group. The muscle that flexes my thumb is called the flexor because it bends it. Pollicis longus, meaning the longest flexor of the thumb. Right next to it is a flexor pollicis brevis. That's the shortest muscle of that group. And then we also talk about the widest muscle, the latissimus. And we all know the big wings that are in our back is the latissimus dorsi, the widest muscle of the back. So those are size descriptions used a lot throughout the whole body. We also talk about the shape of the muscle. very commonly. The trapezius in the neck and back, which I'll show you in some diagrams soon, is shaped like a trapezoid. So it's called the trapezius muscle. The deltoid on our shoulder is shaped like a delta or a triangle. We have a muscle called the serratus muscle, serratus anterior, which holds our scapula to our ribs, and it has a little saw-like pattern where it inserts on each rib. Serratus means saw. We have the platysma, which is the big flat muscle of the neck, and platysma means flat. So those are muscles named by shape. We also then have muscles that are named by the orientation of their fibers. So we have the rectus muscle, which runs along the length of our body. It's parallel to the midline. It's the muscle where we have the six-pack when you have very well-developed abdominal muscles. That's the rectus abdominis. We have a similar set of muscles running down the middle of our thigh. Since it runs along the vertical axis, it's the rectus femoris, because it lies over the femoral bone. We have oblique muscles, many of them, the internal oblique. We have an external oblique on our abdomens. And we have transverse muscles that run perpendicular to the axis of the body, also the transversus abdominis. Those are muscles of direction. Then we have the mechanical action that the muscle carries out. So we have the flexor muscles. All flexors decrease the angle at the joint. And we go from 180 degrees all the way up to near zero. That's a flexor. Extensors take the angle and increase the angle. We have one in our thumb, the extensor pollicis longus. We have a pronator group, which turns it from up to down, pronator. And then we have supinators, which turn the muscles from down to up. And then we have the supinators of the forearm, the pronators of the forearm. Remember the word supine. When you're on your back, you're supine. When you're face down, you're prone. We have levators that lift the muscles or the structure up. We saw the levator ani, which supported the anal muscle at the very end of the GI tract. And we have depressors, which push the muscle down. We have the depressor labii inferioris, the depressor of the inferior portion of the lips. Abductors, abductors, move that part away from the midline, and adductors move the bone back toward the midline. And we have many of those. We have an adductor brevis, a short adductor. Finally, we have tenses, tensor muscles. The tensor fascia lata tenses the muscle at the side of the thigh. You saw the tensor tympani in the ear that put tension on the bone of the ear so that it couldn't vibrate very much, and it modulated sound. And finally, we have sphincters. Sphincters are circular muscles that close an opening. We saw that in the anus. We saw it at the pancreatic duct. We have many, many sphincters in the body. We have rotators that cause circular movements. We have the rotators of the shoulder that allow my humerus to go in a circular motion around the shoulder. And then we also describe the origins of the muscle. The biceps, for example, we're talking now about the number of origins. The biceps of the arm, or the biceps femoris in the leg, are muscles that have two heads. My biceps, though you couldn't see that in the slide, actually splits at the top and has two origins, or heads. The triceps has three origins, triceps brachia. And finally, on our thigh, we have the quadriceps femoris, which has four origins, or insertions. We can name them by both their origin and their insertion, and that gets very interesting. We have the sternocleidomastoid muscle, this big muscle that turns your head, originates from the sternum. It has a clavicular head on the clavicle, so it's sternocleidoid, and it goes to your mastoid bone, turns your head in the opposite direction. Or we can have muscles that are purely named by function. The risorius muscle makes you smile. Something that is risible is laughable. The masseter muscle comes from the word for chewing, the big muscle in the jaw. And finally, we also name these by location. We have the temporalis muscle, that sits here on our temple. It says wrinkle our brow. The zygomaticus muscle sits on the zygomatic bone. And then an interesting one called the sartorius muscle. The sartorius muscle goes from the anterior portion of your hip across your thigh and right down to your knee below the joint. When this contracts, it both pulls the leg up and turns it this way so you can cross your legs. Sartorius is the word for tailor, same as sartorial splendor. And the tailors of old used to sit on the floor and cross their legs and do their sewing. So this was the muscle that allowed the tailor to cross his leg. Put some history into the muscles. This is the big picture of all the muscle names. Now I'd like to go back and show you these muscles as we go through the body, and you can see their attachments and why we call them what we do. We'll get an idea of what they do and their function, which will bring us pretty much through the muscular portion of the musculoskeletal system. Let's look next then at an overall picture of the body. In this picture, of course, all the skin is removed, and you can see some of the really big muscle groups as well as naming them. In the front part of the body, we have the pectoralis major muscle, which originates along the sternum. It happens to have two heads. It has a sternal head and it has a clavicular head. Those two heads join and go under the deltoid, and they insert in the upper arm, pulling the upper arm toward the body and rotating it inward. Now, it also can be used to lift the arm, and that's why when you do bench presses, you push away by shortening the pectoralis muscle as well. Here's the deltoid covering the top, and this elevates because it originates from the clavicle, inserts down here on the arm, and elevates the arm when it contracts. There's your biceps brachii and another muscle called the brachialis, both of which go down to the forearm. And here's the big abdominal muscles, which introduces another term. Here's the rectus abdominis, which are long muscles that go here. They have this tendon between them called tendinous inscriptions. The tendons help support the rectus in its long course, keep it from moving and moving to one side or the other, and gives it strength. Now, it's covered by a very wide covering of fascia. Fascia is the outer enveloping tough tissue of muscles. The fascia is what you like to sew to when you sew muscles together. You really never sew the actual muscle fibers together because your stitches would cut through. You get the fascia on the outside and sew that together and let the muscle heal. When this fascia, which covers the muscle broadly, thickens and comes together in a wide, broad insertion like this as a very big, flat tendon, it's called an aponeurosis. And we have big aponeuroses down here on the abdominal wall. So this is the rectus muscle. I'm going to get a detailed picture of the abdominal muscles for you because they're a very important group. Finally, going down on the leg, here's that sartorius muscle, going from the hip bone across the thigh and inserting down here, which will flex and rotate the leg up to cross the legs. We have some adductors here. Here's the adductor longus, which will pull the legs together in the midline. And then we have the big femoral muscles. Right here is the rectus femoris, with its tendon attaching to the kneecap or the patella and inserting lower down on the lower leg, which would help you kick. And we have big muscles that are vast. We have the vastus lateralis and the vastus medialis, the lateral and medial vast muscles of the thigh, all of which form a cage around the knee. And then not such a good view of the calf muscles, the gastrocnemius and the soleus. If we turn this person around, we get a look at some of these big muscles of the back. Here's the trapezius muscle, which brought together with the other side looks like a trapezoid. Big, wide aponeurotic tendons covering almost the whole back and joining with the latissimus dorsi, the widest of the back. And then underneath the shoulder here, over the scapula, are the infraspinatus, meaning below the spine of the scapula, and teres minor and major. Teres means long. And these, along with some other muscles underneath the scapula, stabilize your shoulder blade so that your shoulder can move. We have the gluteus maximus. You cannot see the gluteus minimus here. And then the famous hamstrings, which are coming down the back of the muscle here, semitendinosus. And these are the biceps femoris tendons. And they insert on either side, and they will flex the lower foot on the knee, bringing your heel up. Next muscles we have here move to the face in this particular picture. Here is the frontalis muscle that wrinkles your brow, and there's the gallia aponeurotica, which is the epicranial aponeurosis. It's on the outside of the head. It's a widespread sheath. Orbicularis oris, which encircles the eye, and some of the muscles of facial expression which give us this human look. These are all muscles which allow us, using the seventh cranial nerve, to change facial expression. We have the levator labii superioris, which raises the labii, the lips, from above. Zygomaticus is named for the bone it attaches to. Obviously, this pulls up on the lips. And then you have the depressors of the lips, which I showed you earlier. Risorius, right here, makes you smile. And then these are the mentalis muscles, which pull the lip down with the chin. Here's the big sternocleidomastoid muscles. And here are some muscles that cover the trachea and are named purely from their origin and insertion. The omohyoid muscle, the sternohyoid muscle goes from the sternum up to the hyoid bone, and then there is also the sternothyroid muscle. If you look at the side of the head, they're very similar. Add on here the big masseter muscle. Here's that flat one, the platysma. You've already heard all these names. And here is the levator scapulae. It lifts up your shoulder blade, the scapula. And there are scalene muscles that are at the flat at the back of the neck that support the chest cavity. Moving back now to some cutaways. Told you I wanted to look more at the abdominal muscles, since these are very, very important in abdominal pathology and physiology. Here was the rectus. The artist has now removed the aponeurosis covering, something called the linea alba, the white line, runs down the middle. And these muscles are part of the anterior abdominal wall. If you look under the rectus, you can see the aponeurosis of what's called the internal oblique. On this side, coming down to the rectus and then covering it, is the external oblique. The external oblique runs diagonally downward. The internal oblique runs across and upward, and deep to that is the transversalis. You have 3 layers of your abdominal wall running in 3 different directions for strength and support. Now, if you look at this on cross-section, if I take a horizontal section through this person's abdomen, here's what I see. Here's the front of the abdomen where the belly button would be, and here's the peritoneal cavity. The lining back here, the thin line that goes along the back, is actually the peritoneum, the parietal peritoneum. The deepest layer, here's our transversus abdominis. Here's the internal oblique, which is obliquely upward, and the external oblique. And they each have a wide aponeurosis that then comes to a tendon, and all 3 tendons join right here and split and go around the rectus muscle, which is coming up toward us out of this picture, on both sides with the linea alba in the middle. If I wanted to sew this patient together, one really easy way to get into the abdomen would not be to go through this. I'd have to cut through fascia here and aponeurosis, all the muscles, fascia here, or all these different layers. Fastest way, and what we do in emergencies, is we go right up the middle through the linea alba. It's white because there's not much of a blood supply, and there's only 1 layer to cut. we would zip right up, usually going around the belly button and up to the chest. This could then be closed in one layer. The disadvantage is it's only one layer, and we don't have the kind of strength we have out here. But it's quick for an emergency situation, doesn't bleed very well, doesn't heal as well because it doesn't have a good blood supply. Moving along now, if we look at this person with all the anterior muscles removed on this side, we're now looking into the peritoneal cavity, and we've also removed all the organs so you can see to the back. There is a muscle called the quadratus lumborum. It has 4 heads and it's in the lumbar portion. Here's where the transversus abdominis goes around the back, and you can see the dome of the diaphragm sweeping up here. Looking at the chest, we remember we had all the muscles, the accessory muscles of respiration, which were the internal and external intercostal muscles that lifted the rib way up so we could expand the chest cavity and take deeper breaths than we could normally take. And here's a close-up of that. Notice that the rectus abdominis actually inserts right up on the chest wall. And it too can be one of the accessory muscles. If you wanted to take a deep expiration and blow the air out, you could contract this and squeeze your chest down to get a forced expiration. Here are the other muscles. This is the pectoralis minor, which you don't see on most pictures because the pectoralis major is so big. It's inserting on the ribs here and going to the scapula, so it's one of the supporters of your shoulder blades. And here are some of the movers of your scapula. Here's the levator, which goes in the back to your shoulder blade. And then here's the trapezius we saw before, which elevates your shoulders. If these are cut, then your shoulder would droop. We go to the back. Here's one of a very important part of the development and evolution of the human body was the placement of this scapula, which is similar in 4-legged and 2-legged mammals. The scapula between the clavicle in the front and the scapula in the back is the place where the upper limb, or the forelegs in animals, F-O-R-E, legs in animals, insert into a socket and move. Now, if we didn't have a scapula that could be stabilized by muscles, such as these muscles here, then if you tried to move your arm against a force, your shoulder blade would move, and you'd lose all the stability of your force of movement. However, if your scapula were nailed down and by a bony fixation to your chest wall, you would lose most of your range of motion of your arm because our scapula moves as we move the arm overhead and around the front. The scapula is sliding around in the back. So we have this nice combination of stability by the muscles that attach on the outside and above the spine that go up into the neck and the shoulders to give us stability and give us motion at the same time. We have a very, very flexible and movable scapula compared to other animals. This is a dissection of the upper arm, taking away the biceps brachii. Here is where it is truly a biceps. Here's the 2 heads, one going up here to the process of the scapula, and another one inserting up over here. Here are some of the muscles that rotate your shoulders. Subscapularis and supraspinatus go behind and allow you to rotate the head of your upper arm. And then here's the tendon that inserts down on the radius so you can flex your arm. And here's brachialis, which gives a lot of added power to the flexion of the arm. See where it inserts down here on the forearm. This tendon is a tendon that gets into trouble because there's often not enough room in the canal. This is the long head of the biceps brachii, and rupture of this tendon means you lose more than half the power of your biceps muscle. And it's of almost no importance. Patients who rupture that tendon rarely have it sewn back because successful repair of this is difficult. It requires an operation, and the brachialis is so strong and insert so close that with the single head of the bicep plus the brachialis, most people who've ruptured the biceps tendon can go on and with training and very little training show no demonstrable difference in the amount of weight they can lift. It can take over very, very well. Looking at the back now, here's somebody is holding a hook and pulling back the latissimus dorsi muscle so you can see where this very wide muscle inserts and goes around under the arm. Here's teres major, another muscle that's one of the big rotators, and then all these insert down here along between the crests of the iliac bone, which is part of the pelvis. Coming to the arm now, this is the palm side of the arm. So these hands are facing you. The fingers would curl toward you. It's interesting to notice that most of the muscles that control the hand are not in the hand. They're up here in the forearm. And muscles like this one comes down here, brachioradialis, goes along the radial bone where your radial pulse is. And you have other ones. Here's the flexor carpi radialis going on the radial side, flexor carpi ulnaris going on the ulnar side. And they pass through this flexor retinaculum. This is like a little pulley. And this is where the carpal tunnel syndrome happens in people. As these flexors go under this little pulley system, they can become irritated and damaged. And these go out into long, thin tendons at the base of the hand and off to the thumb. Here, some of the muscles have been cut away. They've been labeled here, and you can see some of the deeper tendons. And I'm not going to name now, but there's one for each finger, and they too all go under this retinaculum, which means something that holds the tendons back as they go into the hand. Now, more tissue has been taken away from these hands, and these are the muscles that move the wrist. Here is an extensor retinaculum. This is now on the other side, and these tendons go down into the fingers and they extend the fingers. So the other side flex them, these extend them. And they have their own retinaculum on this side. What's interesting here is look at the way these tendons join each other. They come down separately, but then they join in the different fingers, and there's somewhat interesting physiology. It's of great interest of a hand surgeon who may have to repair these. But if you look at my hand on the table, if I were to put my fingers down and tuck my middle finger in, forcing it to stay down on the table, I can raise selectively any one of my fingers except this one. Trust me, I'm trying to raise that finger. You can do it yourself. The reason is both my extensor tendons are joined here. Now, by forcing this finger to stay down, I can't raise this one. I don't have much of a connection between these two, so I can get that one up. I can get it further up if I released my finger. But my fourth finger, and the same thing would happen if I switched and did it that way, I have great trouble now raising that finger, but I can raise the others with ease. So that's a consequence of the attachments between these tendons. And there are people who have further attachments on the flexors. There are people who, when they flex their thumb, also flex their forefinger. Why would evolution allow this to happen? Well, this is the most important function of our fingers, is the fact that unlike the apes, who have their fingers all in one plane, we have what's called the opposed thumb. We're the only animal with an opposed thumb, and we have fine grasp potential because of the opposite or opposedness of our thumb. And so therefore, having a tendon that works together really is not harmful and rather beneficial. Getting back to the hand, we can also see that we do have a few muscles in here. These are called the interosseous muscles of the hand. And those muscles are between the bones, and these are the muscles that allow us to do that. But all the rest of the muscles of the hand, by and large, are working from the forearm. And when you cut tendons in your hand down here, these muscles contract pull the tendons way back, and that's the hardest part for the hand surgeon who's going to fix that. He or she has to go back up here and find those tendons and pull them back down into the wrist. If they've been left up there for a long time, those muscles may go into a contracture that's chronic, and you may not be able to get those tendons down, so they have to be fixed fairly promptly. Going back into the legs now, this is the cutaway of these huge muscles. I mostly want you to see this to just see the magnitude of the size of the muscles of the front of the thigh. The reason is they have a very, very poor mechanical advantage. They have this long, long distance, but here's the fulcrum, the joint, and it's just going across a little bit. So the mechanical advantage or disadvantage here in that fulcrum is that we only have this short distance here and a very long distance here, and it's going to take a huge amount of strength to kick the thigh forward in a kicking or running, stepping motion. To do this, we have very, very big muscles, and the advantage we're going to gain is speed. We're going to be able to move that foot forward very fast with a long range of motion. Here are some more muscles of the thigh. Here's that tensa fascia lata I told you about, and these are the muscles which adduct the thigh on the pubis. They pull the thigh in. Here's adductor longus, magnus is the biggest, and brevis is the shortest. The other part of the function of the thigh I wanted to show you when we got to the back. You have those tendons around the front of the thigh on the quadriceps muscles, and now you have the tendons along the back here from the hamstring muscles, the biceps femoris, semitendinosus. There's another one called semimembranosus, it's membranous, and there's also a gracilis, which is slender. If you look at these on the back, which again cross the knee joint and insert on the lower leg, and the ones in the front, they all form a cage around your knee. That cage protects the knee from instability. You have ligaments, you have medial and lateral ligaments, which we managed to really mash up in football. You have anterior and posterior ligaments, I'm going to show you in another lecture, that prevent slippage front and back, but they all can be injured. The real strength in the knee and the protection is that cage of tendons that come from your thigh, front and back. The first thing that happens when you get a knee injury and you're immobilized, or a leg injury and are immobilized, is those huge muscles of especially the quadriceps atrophy or lose their bulk and strength faster than any muscle in the body. We had, at the beginning of the real upsurge of professional football, when the orthopedic surgeons began to specialize and learn a lot about knee injuries because money was involved, we had one of our professors was the doctor for the New York Jets. And he had the entire medical school class all sit on tables, and he walked around and examined everybody's knee very quickly. He then came back and said, you, and you have had injuries 10, 15 years ago in high school, and your knee hasn't recovered yet. And he was right every time. Unless you have compulsive, continual physiotherapy after one of these injuries, you actually lose the strength and never gain it back again. Then your knee becomes prone to more injuries because you don't have the cage. So the most important thing in treating these patients is to make sure that they get intensive physiotherapy, re-strengthen the quadriceps, and protect the knee joint from further injuries. And that's what professional football has done for orthopedic surgery. One more structure before we finish. This enormous nerve comes back here under the piriformis and out of under the buttock, really, and into your leg is the sciatic nerve. This is one of the thickest nerves in the body. It's as big as my thumb. It innervates almost the entire leg, except for a few muscles on the thigh. And another big misconception is the need to stretch the sciatic nerve. You hear yoga teachers, exercise mavens telling us to do this. You cannot stretch a nerve. You can only damage it. Whenever a nerve is stretched, it is injured, period. You can stretch the muscles, the ligaments, the joints around that, but you must never try to stretch a nerve. It doesn't work. It only causes injury. So this is really a quick Cook's tour of all the muscles of our body. Next time we'll look at some more function in the musculoskeletal system. See you then.